Welcome to KIMEcast, where we break through and cut the BS in sports medicine, rehabilitation, and sports performance, and talk about how things really work. All right, welcome to KIMEcast. I'm Tony Mikla, Russ Dunning, Evan Hauger, Aaron Crouch. We're going to take on movement today. We want to talk a little about some movement assessments. We've had some good questions coming in through social media about how do we assess movement, how do we look at movement. So let's take it through and talk about some movement assessment recommendations and options and how we use it in our day-to-day strategies with our clients and with our athletes and such. So, but Evan's got the lead off here as to what are we drinking tonight here?
We are drinking a beer from Device, local in Sacramento. Yeah. This one is, they say beer with a purpose, which I like. That's nice.
Absolutely.
This is the Made in Sac West Coast IPA. I really like. This is a good one that I enjoy.
It goes along with Run with a Purpose.
Run with a Purpose, right.
Goes to the jogging concept.
That
was on another episode. Yeah. Highly recommend you listening to it.
Strong colors in this can.
It is. Blue.
Yes.
It's nice.
And red and white.
Interesting.
Yeah.
Indeed.
Power tie. Type.
All right. So as we take a look at movement, I mean, this is this topic. Obviously, I think the purpose and the reason for some of the questions on it is, what's the target? How do you start with it? Where do you start with it? What's the way that you approach it? And I think obviously there's a lot of stuff out there, really high end stuff, 3D motion capture, forge plate stuff, super simple stuff, maybe like FMS or SFMA, super non-technology, a little simpler version of stuff. So let's talk about what we do. And what we do, what we found to have a lot of consistency with and things that we use clinically. We've definitely built a model around using movement as a foundational tool for us. So we do use many of these tools, many of these tests, and let's kind of describe how we use it so that you guys can listen to a perspective on how we found to use it over the years that I think has been really super efficient. At the end of the day, I mean, I think you can get really lost and get pulled in many different directions here. So let's talk about what we do and why we kind of do what we do. So who wants to run with that?
I think first off, there's no wrong or right way. I think most people can hopefully accept that it's ultimately whatever gives you yourself, the clinician or your team, the right information to make the right choice. And so with that, we've kind of identified the SFMA or Selective Functional Movement Assessment process to kind of align with our treatment strategies. And so the SFMA offers up a nicely laid out algorithm of looking at top tier movement patterns that most people should be able to do. And then if there's any deficiencies, it really dives deep into deciding whether this is something you should attack on the table or something that maybe you just need to regress the movement pattern a little bit and facilitate some rudimentary elements. And so, I mean, we have our younger therapists go through it because it is a nice starting place. It allows them to make a decision and to guide their treatment plan and really educate the client like, this is what I'm finding, this is where we should go, and this is how I can correlate it to ultimately what you want to get back to.
Yeah.
I think it organizes their thought process, first off, right? It gives them like this funnel of stuff. So the top tier tests, right? There's a few top tier tests, and you find things that don't qualify, and you've got these breakout versions that can just kind of train your thought process down this idea of looking at, is it a movement dysfunction? Is it motor control dysfunction? Is it whatever? You start to break it down to its components. Organizing that thought process, I think, is super important. The biggest thing for me, at least in the movement assessment, is reps. You've got to gain these reps of seeing the same movements over and over again, so you know what kind of qualifies as good versus bad for different reasons, right? Like you might have a different idea. So if we talk about multi-segmental flexion, it's one of the top tier tests there, touching your toes. You might have a different qualification in your mind of what a gymnast should look like versus a 70-year-old man should look like in that. Right, so I think you need to build up reps.
Yeah, or even I think that's important to note because I think each individual person should be held to this similar criteria of setup, but then held to a different standard of performance based on what they have experienced in the past or where they want to go. I think you always have to keep in the back of your mind, they're sure we're going to lay out like this is something you should dive into based on this measurement, but at the end of the day, someone that operates at a very high level kind of has to be graded a little differently than someone that maybe is just conducting their normal daily activities of walking.
I think it's a good conversation on that specifically because I'm a big fan of Gray Cook, and he's been a mentor of mine from the beginning. And this, I would highly suggest that therapists start with the FMS and the SFMA process. I think the SFMA process is a really good process for clinical work, and I think the FMS process is probably great for more prepare for discharge or return to sport or higher level activity, kind of kinetic linking, like is everything working together effectively? So it's good in that kind of end stages of rehab, but pre-stages of sports performance or of fitness training. So I think the FMS kind of fits in that space. But I do think it's a great tool to start with because it really challenges your mind for thinking. And this is a comment from Gray, which would challenge that thought. And I'm not challenging it myself necessarily, but I think that what Gray speaks to one thing. I think it's a good quote is, if you look at vision, if you take someone, you look at an eye chart, for example, if you say, if you're 20 years old and you go to the eye doctor, you look at the eye chart, you're 20 feet away, and what is that row? And if you're 80 years old, you go to the eye doctor's office and you look at the same damn chart. So the chart doesn't change, and that's a big question that challenges his development of the FMS and such is, should we change the test for the person? And I think we all would agree, no, let's not change the test of the person. Let's not change the eye chart, but maybe let's change our expectation of the result, as you were indicating, right? What do we expect that person to do? And I don't expect someone who's 80 to have 20/20 vision with no assistance, nor might I expect an 80-year-old to do an overhead squat with no problem, get a 3 on an overhead squat. I wouldn't expect either of those two things to happen. So what's the allowable variance? And to your point, that's, I think, exactly what you're saying on the experience side is what do you start to expect and what's acceptable?
Sure.
And let's take those next steps as far as other things to dive into. We use those tools extensively in the start of our treatment and our treatment programming. We use them with a mindset that backs them up. So the mindset is when I'm looking at these movements or these skills, I'm looking at a joint by joint approach, and I'm looking at what things move and what things don't move. And then I'm thinking about the fascial line. So at this point for me, when I watch somebody move in my brain, I'm seeing them move kind of in 3D and kind of removing the skin off the body in a gross way. It's like, does the joint do what I want it to do? Does it do what I expect it to do? And then does the fascial lines allow for the movement to happen? Does it have control or does it have tension? And looking for those variables and in that manner. So is this a joint limitation issue or is this a soft tissue limitation issue? Or ultimately, in Gray's words, is it a motor control issue? And I think that holds water for sure. But the perspective is key, that you go into this movement screening process of like, what do you expect to see? And then what are you going to do about it, right? Because, we could pick apart the overhead squat here all day about how good it is or what it isn't. And the FMS has been highly criticized, I think, inaccurately, mostly for like, oh, is it a good movement screen or is it a poor predictor of injury and all these things? It's like, well, that's not what it's designed for. It's designed to be a quantitative way to measure movement and have a standard analysis.
Yeah, I think if you look a little bit at the history of testing movement, and it was easy to look at testing in terms of ligament testing and joint testing. And when I went through PT school, it seemed like I was inundated with about 100 tests. And if you're going to assess a neck, you have to do these 20 tests. If you're going to assess a knee or a hip, you have to do these 30 tests. And then, with each passing year, oh, there's that test. Oh, I didn't hear about that test. What does that test do? And then so you get this litany of tests, and it always felt like when you saw a person, you're basically having a shotgun. And it's just like, well, I hope I find something here. And for those of you who haven't gone through the SFMA process, what I loved from the very beginning is it looked at a top tier movement. Let's move your neck, move your arm, move your full spine, get into a deep position. And let's just start there and see, is it painful or are you able to do it? Does it look like that you're uncomfortable or you're lacking of freedom in that deep position or long position? And then you really kind of start to explode that thought process with the breakouts in terms of joint integrity, fascial line opening, motor control, and how smooth and efficient is that pattern. And really your stability. How well can you root through the ground or root through your own proximal self? And I think the word that I really love the most, it's kind of, I feel like it's my word, it's not really a company word, but I look at freedom. When you get into a difficult position, do you have freedom or is your body pinning you in this exact position? And that's when we see, say a deep squat, you notice a valgus collapse. In of itself, valgum is not the enemy. But if you can't take your knee into verum in that deep stance, that means every time you get up from a chair, you're grinding on that meniscus. I think it's going to get pretty arthritic after a while. And so I think looking at the freedom and efficiency of your patterning and what you do in your activity and in your sport and in your life is a big deal. If you kind of zoom out and what am I looking for through the SFMA process? What am I looking for through a lunge, a squat, a push-up, a toe touch? We're looking for some freedom. How good does that feel? Or do you feel pretty gummed up, tight, or in pain?
But I'm going to come back to the point I made earlier about reps of seeing the same movements over and over again. So when I first learned how to do the FMS, I would look at the inline lunge and I would think of the qualifications, and that would be almost all that was going on in my head. And then I would listen to Gray Cook talk about it, and he would talk about that same movement, but he would talk for 10 minutes on all the things he saw there. And so for me, there's always been value in even if somebody's coming in with a big toe issue, I'm going to look at all of these top tier tests, because I'm just putting reps in my head, seeing these same movements over and over and over again, so I can start to make some of these same kind of connections and explanations that I've heard him make before.
Yeah.
So,
And then to ultimately ask what matters and what
Right.
doesn't matter, right?
Yes,
Does that move the needle or does it not move the
Yes,
needle? And I
exactly.
think that ultimately is a massive question for us to tackle in the movement science is what you're looking at and trying to make a change there. Does that really move the needle? And that comes down to what's the person's day like? What do they want to do? So if it's a baseball player or a golfer or a volleyball player, they're a rotational athlete for the most part, we're going to expect some movement dysfunctions that are biased to certain rotations, and that's welcomed and that's great and to be expected. We don't expect them to move the same both directions, and I think that'd be an anomaly if they did. But there's also some assessments that we bring into the account here that you have to be really specific on for baseball. Like one of the things being like external rotation of the shoulder. If they don't have that variation of more external rotation on the throwing side and less internal rotation, they probably can't throw very well. So it's like there's certain variations of movement that are good and necessary for sport, and then there's other ones that are not. And I think that really where you have to dive into what's the purpose of the movement, and then what moves the needle for the person.
but you need to look at it through the lens that you mentioned earlier of the fascial lines and the joint by joint approach. So seeing all those top tier tests and looking at cervical flexion, somebody whose toe hurts, doesn't really matter if you don't understand the potential force connections there. So you're talking about valgus and the squat earlier, right? Valgus in a squat, each of you guys could name about 30 things that could lead to that have nothing to do with the knee. And almost none of them would have anything to do with the knee, right? So, but if you're not looking at these, that's the whole idea of the joint by joint approach, is looking above and below and trying to find the other contributing factors to this. You won't find those if you just sit there and look at the person's knee and do the Lockmans and the valgus and the varus test. We need to assess the hip. We need to assess the ankle and the foot and these more global movement patterns if we're going to find those connections.
I think the art sometimes with that too, which is absolutely something you should do, is if you don't know what the joint by joint approach is, or anatomy trains or fascial anatomy, I think those are excellent avenues to dive down for your own knowledge set. But I think what you also have to understand is that the person that you're seeing also has a concern for a singular area of the body. So you could find a lot of different things in someone that's dysfunctional. If you get a little bit lost in the weeds and okay, you got some tibial external rotation deficits and your low back's hurting up here and you only work at the foot, you're going to lose them. And so there's a benefit to finding everything and logging it in your mind, and the art is being able to store it, remember it, and then return to it when it's necessary. But in the moment, you have to address what you're finding that's relative to the body region they're seeing you for.
I had an eval the other day, and the guy said, I'm a golfer, my back hurts. And then I kind of asked, and maybe I looked a little too endearing into his eyes, but I said, hey, Chris, Chris, tell me what else do you do? And I just kind of said it very, in a humble fashion, but maybe it was just a little too intense. He's like, is this like some weird shit, or like what else do you want to know, man? What else am I into? And I kind of chuckled. I'm like, all right, I want to zoom out. I want to know what your body has done 10 million times. Tell me that answer. And he's like, I sit a lot at work. Bingo. I want to know that at least you're aware you're a professional sitter. Good. We started there. And so I tend to think you're a professional something. What is it? Are you a professional extender? Are you a professional flexor? Are you a professional rotational person? Like many people, do they sit? But maybe some people they stand and walk an abnormal amount of the day for whatever reason. But trying to zoom out, I like this, especially with pregnant women. You just carried a baby for 9 months. You got really good at that. You're professional at it right now. unfortunately. So I think zooming out, where does the body done 1,000 reps? And you start to understand, of course your posture is like that. Chronic posture, dynamic posture, call it what you will. Your body's been a little bit contorted and kind of held there for a while.
Yeah, I think that's a huge point. Is like it's so easy to get sniper vision into okay, what is the movement dysfunction? What is the mobility restriction of this joint or this soft tissue or this motor control element versus being able to like step back and see what continual habits make up the structures in their body and the postures they're presenting with. Or even little things like, is that thigh smaller than that thigh? And why do you have knee pain? It seems correlated to that thigh that is a little bit smaller because it's not tolerating the deceleration load you're asking upon it for everyday activities. So taking that step back is so big, and it can happen before any movement screen you choose to do even is conducted.
And that global look can be so simple. Like you're talking about extension versus flexion. You think about the gymnast that's always an extension, or the pregnant woman that's been an extension for 9 months. Our job might be to get them in a little bit more flexion in a very simple look. Or your desk guy sitting there, he's in flexion all the time. Our job might be able to figure out how to get him in a little bit more extension. If you look at it, it's most basic like that. It can kind of help direct some of the more detailed assessments that you do.
I think it's pretty fun. I like, whenever we have a student come in and we're kind of having some banter and we get a new patient walk in, if I see, and I'll talk with the patient, and if we know it's an eval, and I'll see, I'm like, oh, looks like we got an eval coming. I think it's a back pain patient. I'm like, why do you think that? I'll say, because he's got no ass.
Yeah.
And they'll look at me like I'm the most weirdly kind of oddly vocal person in the world. Like, can you argue that? Yeah, but watch him move. He's going to sign that. Let's see which body part he chooses to use when he goes to sign that document. And he'll, boom, he'll bend at the back rather than bend at the hips.
Mm-hmm.
We have an underused butt. No reason for you to build up gluteal tissue.
Sitting on it all day.
So-
What could you expect?
Yeah,
Hasn't fought gravity, never how long?
So, good story on this with Russ. When I first met Russ would talk about his patients in kind of interesting ways like that. But I remember him saying a couple of times, this person's a lifer. And in my head at the time, I was an undergrad student. I was like, well, what the hell? Isn't he stupid? Like, isn't that a bad thing if they're not getting better? But I didn't realize, it took me a little while to figure this out, but it really is that, yeah, you can address the problem, but you're going to find other issues down the path. And that's what these movement screens lead you to, is how to help somebody kind of optimize themselves. And I think Russ has collected a lot of lifers here, and it's not about them not getting better. It's
if they've wrestled,
let's
say they wrestled for 20 years and they wrestled at a high level, welcome to me. I'm going to know you for the next 20.
Right.
Why, Russ? Because you were doing this for like a long time.
Right.
So we're going to have some shit to deal with your neck, with your shoulder, with your back, with your knee. Like, of course, and that's why
Absolutely.
you tend to collect these high level runners.
Mhm.
Of course they're going to get injured. They're running a lot. I mean, that's a
Jogging
very
a lot,
difficult
that's
thing
what-
to
they're
do
jogging.
100 miles a week, and when you depending on what kind of posturing you do, whether or not you're a wrestler or a runner or you're a basketball person, if you've done a lot of something, welcome to us.
I mean, that's what life is. It's about repetitive. It's either the sitter that's sitting for more than 8 hours at work and then at home for a number of whatever it is, or it's a rotational athlete in golf or baseball or tennis twisting the same way over and over again. And everything we do is repetitive. And so stuff's going to break down. And so it's about finding the opposite.
Yeah. And that's what you're combating the most. I mean, at the end of the day, we can talk about movement assessment all day long, but knowing the individual and their background is just as valuable. So whatever movement assessment you're choosing, really, if it's giving you a thought process, giving you a direction for your plan of care or daily routine or whatever, that's fine. But understand the person that's behind all that and what they're coming to the table with, essentially.
Yeah, so I think we talked about, we do use the SFMA on a regular basis in our clinic, and that's kind of the foundational part of the evaluation from an objective standpoint. Is let's go through the top tier and go from there. We may not do every single breakout, that's for sure, but we use that information to say, okay, where do we go? And then the next step would really be to think about the joint-by-joint approach. And we're looking for, does the ankle dorsiflex, does the hip move, and does the thoracic spine rotate and extend, essentially? So do we get those movements? If you don't have those movements, then you need to pretty much stop and go get those movements, because if they're not there, that's what's probably leading to your problem. If you look at the orthopedic nature of the world, most people have back pain, low back pain, and then shoulder pain, and then knee pain. So those are your top three issues. all of those are surrounded by joints that tend to get stiff, right? So your shoulder gets hurt because your thoracic spine is stiff. Your low back hurts because your thoracic spine, your hips are both stiff. Then your knee hurts with a hip and ankle stiffness, and it sits in between. So we see this pattern over and over and over again. So when I'm doing a movement screen, I'm looking for those three mobility segments. Then if you get that cleared and those things are moving better and moving well, so what we're talking about here is like, what does the person do best? You have to start to look at kinetic linking and the kinetic chain is how, at the end of the day, when you're looking at someone's success in movement, it's how well does force transfer through the body. So can someone put force through the ground and then transfer it into something they're lifting or something they're pushing or something they're throwing? Can they transfer load from the earth into an implement or into something they're carrying or whatever it might be? So can they transfer force? And if they can't, the point that they fail is probably where the pain is going to be. So to Russ's point, I'm looking at the guy with no S. He's probably not hip hinging very well. So he's just flexing at the spine and right out of the gate going to lift it off the ground. He's probably going to fail because he's not able to use the lower extremity pattern very effectively. So you have to think about how is this person transferring energy through the body and where is all the force going, and where it ends up going is usually where your point of breakdown is going to be. And our job ultimately is how do we make that transfer smoothly? How do you load a system and transfer energy through that system in an effective way? I would say that the biggest thing, to take away here on when we talk about posture and this idea of what have they done 10,000 times and stuff is fantastic. And I use the thought process of that everyone's training. You're always training, right? And the concept that change is inevitable. That you're always going to be evolving and changing. So someone might say, well, I haven't trained in a long time. Well, what have you been doing? Well, I've been sitting at my desk. Well, then you have been training. You've been training to sit really well. I bet your cardiovascular system is shit. I bet your hamstrings are tight. I bet you got no abs, no ass to your point. You probably got a little flexed spine posture. You have been training. You just didn't realize it, But your body's adapting every day to say, like, well, if you're not going to make me go sprint or go do something athletic or something demanding, then I'm just going to whittle away and get weaker and weaker until because I don't have to use those things, right? And so then all of a sudden you stand up and you're like, hey, it's the weekend and I'm going to go, work on my house or do something. And then all of a sudden we've got problems because you're not in condition for it. My dad has a great story on this. It's funny. He worked for 35 years, mechanical engineer, sat a good amount of it, had an hour and a half commute into the Bay Area and then back out of the Bay Area. So he was like in the car 2-3 hours a day. When he retired and he started work, went back to the house. He grew up on a farm, so he's active, he's never worked out a day in his life, but he's like in shape, like healthy, like active person. He was sore for a year. He said that to me. He goes, like, my back is sore, my hips are sore, my thighs are sore, my shoulders are sore, because he's working on the house all day. And for the prior 35 years, he's been sitting at a desk, like looking at a computer, working on making parts for trains. Yeah. So it was a really interesting transition for him. And then now that's been 5 or 6 years removed, and he's great. But so that adaptation takes time, and your body's always adapting would be one of my main thoughts.
I think a nice spin on that. When you think about that, breath is a hot topic, and analyzing breath with movement and speaking to between cardiovascular health. If you're more sedentary and your heart and lungs aren't used to whether it's not used to bringing air into the lower lobes of your lungs, or your heart rate doesn't ever really go up, so you don't get that massive oxygenation perfusion through your body. When you're lacking from a cardiovascular sense, or you're lacking from a postural sense, we're going to have some breath issues. And I think it is a hot topic. And what I love with using the selective functional movement assessment is slowing things down, getting into whether it's a deep squat or really what I really love is a rolling pattern, and saying, if you slow it down, eventually you'll have to breathe. And if you have someone stay in any position for a while, you're going to see them take a breath. Because I think that, they can tighten up and they can cheat in a lot of ways, with whether it's like a mild Valsalva or some kind of a, move. And I like doing the SFMA insanely slow. And when you do a rolling pattern, go insanely slow. When you go into a deep squat, stay there. Look at your watch. Hang out. And you're going to see real life functional breath and see what happens with them. And I think it's another tease of kind of, what about this, guys?
You're such a mean person.
But well, yes, but I almost like the opposite of that too is look for no breathing. I always find when somebody can't breathe in a position, then that generally is saying that their system is not comfortable there, they can't sustain life, or they haven't been there in 10, 15, 20 years or 10 months or whatever it is. If they can't breathe in that position, that's almost more telling for me than
It's a stress posture.
Exactly. It's a stress position that their body cannot function in.
I think. Oh, go for it. Sorry. Continue on. You're like mid-thought.
That's all right. I was kind of going to shift gears a little bit and just kind of try to organize a thought process here. Like I need to be a little bit organized on this in my own brain. I think we've said a lot of stuff. And the question or the original topic at the beginning was a movement assessment. And I think we talked about this guy with no ass. So I think this is a good example here, right? But we could look at multi-segmental flexion. That's what you said, and you said, okay, maybe he can't get down there to touch his toes. We don't really know anything about that yet. That's the screen, right? That's the gross overview of this movement. If we really want to know how we attack that, we do have to get a little bit deeper and assess. We have to find out if maybe his hip can't flex enough, or maybe his lumbar spine doesn't flex enough, or maybe it's a movement issue. Maybe he has no hip hinge pattern. He doesn't know how to load his hips. To your point. But there's got to be this organization of a thought process, and I think that's what the SFMA has done for me. Mm-hmm. And then I can take that concept and apply it to any different movement. That the thought process has been the most critical piece.
Yeah, I think you take that and we use a continuum model here. It's along the same lines, right? As in your evaluation process of the continuum starts off with pain, then goes to mobility, then strength, and then speed, and then performance ultimately. So if you look at somebody and they're coming in and pains are based on the manufacturer, then the movement assessment doesn't make a lot of sense. I mean, pain's it. Like, let's gotta get the pain down. I got to put the fire out first and foremost, right? Mm-hmm. So you start with that. And then once that starts to calm, then you can kind of get into looking at some mobility and let's check those boxes. And the big boxes, like we said, was ankle, hip, and thoracic spine. But there could be some other details, elbow for sure. Maybe, anybody can have some stiffness somewhere. Find those spots and start to address those things if they affect the kinetic linking process, right? If it's going to move the needle. And then from there, it's about control, as Russ said. Russ said, I want to look at someone do it slowly and under control. Do you have that segmental control in your system? And we do a lot of work here as a group with our bulletproof process on looking at stability and control. Is really, really massive, and I think a missed area of so much in the way of sports performance and even sports medicine. So it's a huge factor. It's looking at control first, and then looking at strength building, and then ultimately, if you have all of that, power production, rotational power, explosive linear power, linear speed, those things should just fall into place and are really straightforward. You don't need any fancy drills or need to get nuts with that. And you can really dial in those patterns and get good at them if you don't have mobility deficits. And if you don't have control deficits, then those things become easy.
I think at that point, you've passed these tests, say you've gone through our continuum, and we checked a lot of boxes, and we've developed some good patterns, and we've got some good strength of the system. It's very appropriate to whip out your phone, whip out some kind of tablet, and get some motion analysis. And that's where I think the research of looking at the throwing motion, the hitting motion, the sprinting motion, we all need to be nails here. This is if you're managing anyone with an ACL reconstruction, you need to know your shit when it comes to sprint mechanics and cutting mechanics. You can't just think, well, that's high level sports medicine. I don't really treat that population, and I let go of my ACLs at 3 or 4 months. You let them go because you don't know what else to do. And I think having some good tools in your skill set, being able to analyze that motion. If you don't know how, then you need to read. You need to follow some smart people. You need to listen to some smart people and figure out, get that motion analysis. And, I'm not sure how many books I've read on this, but I feel like the easiest way of looking at a run is I'll do a motion analysis of some ACL kid 6 months out, and I'll look, is that right side looking like the left side? I mean, that's always the best part about gait. I know with a hit or a throw, it gets a lot more dicey. You can't just look at, the left-hand throw versus the right-hand throw. But you really got to know your stuff when it comes to speed, analyzing speed.
And I think to that point, what we do in a lot of our facilities is we're teamed with performance coaches or sport coaches. And I think going to the expert is awesome. And when you can have that discussion with the expert, when the athlete is working back into the sport, when you can walk right over to their coach or walk right over to their weight room coach or whoever it is and have that discussion with them, it's always going to be the most authentic then. They're going to have the most real look at what's going on at that point in time. And you guys can kind of collaborate, and that's when I've seen the most success.
You gotta watch your people move at the end of the day. I mean, and move in as much in their environment as possible, right? So if they're a baseball guy and they throw, and you got a clinic where you've got 800 square feet and you got a trampoline, like that's not going to get it done. Ask them to videotape themselves from the front, from the side, and from the back, and then have them bring you that video or send it to you and take a look at it, because you've got to watch them compete. Because I think that's the thing. That's the kinetic linking it in real life. And if you don't see that, you could have all of the boxes checked. This is the trickiest thing, is you could have all of the therapy stuff checked. Like FMS looks amazing. Their SFMA looks amazing. Their mobility looks amazing. Their control looks amazing. And then you watch them throw a ball and you're like, ooh, that's not amazing. That's interesting. And that's a problem, because they're not linking the stuff together. And then it might be a coaching issue. It's like, let's find you a coach that can help you understand how to link this stuff together. Or if you're in that space as a rehab clinician or as a strength and conditioning coach, maybe that's you. But I can't emphasize enough, watch your people move in their environment. It's something that's very difficult for all of us, because we're usually talking, whether it be in a weight room or in a PT clinic or whatever it is, chiro office, you're in a building. And sports aren't really played inside small buildings.
No.
So if you want to know the truth, and I can't emphasize it enough, and as much as we try to send our clinicians out, and I go out every time to a football game if I can see it and get on the sideline and watch the game from the sideline, the speed of the game, the amount of impact, you cannot reproduce it in the building. Same thing with basketball. It's the speed of the game is insanity. You can't reproduce it. Same thing with baseball. On a dirt mound that's a little bit vulnerable, and you're going against a live guy and you're trying to get him out 27 times in a game, that's different.
I think it's the competitive component of it too,
Yes.
right? You can be in a cage in baseball or in the practice gym basketball or whatever it is, but when it's a competitive thing, you're no longer thinking about the injury. Everything, all of that is out of your mind. Your one goal, to your point, is beat the guy in front of me or beat them at whatever task it is, and so everything else is out the window. So yeah, the competitive part of that is, I think, even the biggest key.
Yeah.
You can't replicate that in the game.
I think myself and yourself think very clearly, or very similarly, and I kind of relate it back to a quote that I really repeat in my own mind. It's "stand upon the shoulders of giants." Sir Isaac Newton. I'm sure it's not verbatim, and 6% beer kind of does that to my brain. But that is such the truth of the world, right? And there are so many people coming up with good stuff, but in silos. And in reality, if you can take your brain and create a framework for all these little pieces of information, from movement assessment to lifestyle management to singular sport specific skills, to then bring them all together and see a very clear picture, I think that you're going to be a very good assessor of the person across from you. Like, for me personally, I had a conversation with our younger therapist earlier today, and I said it all has to, like, your decisions are based on a certain framework that are consistent with every single person that comes in front of you. And for me personally, it started when I first was getting going with things. I didn't have a framework of thinking coming out of PT school. I had a myriad of tests, special tests that would tell me what tissues involved, maybe based on specificity and sensitivity. But what was helpful for me was listening to Dan John talk about movement patterns, and he summarizes things like insanely well. But he basically just said the human body moves in a push, pull, squat, hinge pattern, and a carry, and then the sixth movement, which could be anything else that you want to do. Single leg balance, get up, whatever the hell that you love. But you use that as the framework of, this is where I need to take someone to be able to squat, hinge, push, pull, carry. I need to then use that as a foundation to have them move on to speed and impact, sport specific stuff. Or I can deconstruct from that and move down to the ground maybe, which then I get from someone else in the FMS system. Gray Cook and his partners would suggest that the easiest position to learn anything is from the ground. You've eliminated gravity, eliminated the fear of falling, and then you've started on your back. So then start on their back, their stomach, half kneeling, full kneeling, then get them up to standing. And then you can change their base of support. And so you have this framework of thinking that allows you to kind of plug in specific deficiencies or your strategy to improve their overall movement pattern, their sport-specific capabilities, or even their table time. So you think about, like, I even have to reset the body to even get to some of that stuff. And so what is the framework around resetting the body? And that's its own conversation. But I think if you had this thought process that there are sport coaches you have to listen to, and there are movement specialists you have to listen to, and there are people that understand movement progression, exercise progression, and even more of a hands-on therapy approach, you can take from different entities and formulate this really cohesive plan that's outside of just simple movement assessment.
Completely. I think the quote is, "If I've seen further, it's by
Please.
standing on the shoulders of
Thank
giants."
you.
It's on my wall at home. That's why I know that. But
Well
I
done.
had a
And
mentor-
also, we had a brewery down in Sacramento.
yeah,
you know that?
it was at it was
Yeah.
at
Sacktown.
Yeah, Sacktown. So
Knowledge here. Jeez.
just bear with us here, please.
Bear with us.
Oh,
It's
it's
candid
all right.
talk.
So I think another way I've heard this said is a mentor of mine, Mike Ryan, would always say, everybody needs to be a mutt. You need to take stuff from all of these different things
Yeah.
and kind of create your own system that works. And that's always rung true for me. Is you got to pull things from different places. You put it all together cohesively, which is exactly what we've talked about today: is fascial lines, joint by joint approach, SFMA, FMS, Dan John. Like all of these other people have come up. We're not reinventing the wheel.
No.
We're taking all of these other ideas and kind of putting together a cohesive package and blueprint to kind of create the stuff.
And if you look closely, most people that come out with a various movement assessment, they're kind of saying the same thing. They're just saying it in different words.
Yeah.
It's no one's reinventing anything.
No.
It's just repurposing it into their own thought process.
so they
'Cause
can
everyone
$1,000
sees
on
something-
a weekend course.
Well, I mean, maybe, but then also because everyone sees through something through a different lens. They see the same solution through some other perspective that you just kind of have to respect.
Yeah, it all comes down to people talking about the same thing.
Yes.
I think for our next segment, there's really no other thing to talk about except for a goniometer.
Of course.
I mean,
Which
it really
asks,
sums
wait,
up.
no, there is a question. It's what the fuck are we doing?
I
I have never once, other than we're being required doing it during a pro bono and PT school, to use a fucking goniometer. I'm not carrying one in my pocket. It's not sitting outside my back pocket to show everyone what I can do with this thing.
Well, that's because you have the fanny pack.
'Cause I
Don't you wear
have-
that pack?
Exactly. I do have a fanny pack.
Khakis
You know what I
and
put
polo
inside
and
of
the whole deal?
it? I put my phone inside of it, which everyone has, and it can serve as a better goniometer. Just like that.
Yeah.
If you have an Android, I'm sorry, 20% of you, but you can download the inclinometer. Either way, the goniometer,
You're saying
I mean-
goniometer?
I think it was a goy.
Is it? Is
I don't
that
even know how to use
goniometer or
it. I shouldn't have to know how to say it.
Yeah, that's a fair point. I'm
kidding
not
me?
sure.
So yeah, I mean, obviously we've gone off a lot about movement here, and you know, the at the end of the day, you know, we're trained in how to use this this device to measure range of motion at these specific joints, and you just have to ask yourself again, what are we doing, and why are we doing this, and what does it tell us? And you can argue that we're doing it for an insurance company, which is really a terrible argument, and as a group, we need to be stronger than that. You're looking at range of motion, that's critical, obviously, in a certain joint and measure objective gains and things of that nature. But the error on these things is so outrageous, it's really not even worth a decent measurement. And then at the end of the day, you're really trying to connect what's it to functional activity. So the point of this kind of taking this head on is not to say that the Goni is stupid, although it might be, is to say that, you know, don't get lost in just doing the goniometer and be like, oh, it's 163 and now it's 168. Wow, that's a huge improvement. Like, we're missing it by miles if that's what we're looking at as a group.
Well, we all have a built-in oculometer, which
Yeah.
can
Yeah, which
Probably
should be able to
detail.
tell you how to do
Yeah,
that.
right. Yeah,
Just so
like-
it's not the 5-degree difference. It's we want to see a bigger global.
Yeah,
like a
yeah.
if
Even
you're-
though
if
3
it's
to
10
5
degrees,
is statistically
your oculometer's
significant.
got it.
Yeah.
If you're making
Whatever.
3 to 5 every 30 minutes, you got to switch up your
Well,
stimulus.
Yeah, that exactly, and I think you're missing the boat. Like
Yeah.
gaining range of motion is no longer challenging, especially with the modern day surgeries and approaches. You shouldn't really be struggling with gaining ranges of motion and getting joint mobility back. It's so much better than it was a long time ago, and I think for that reason we need to challenge ourselves in looking at movement assessment more dynamically and more as a whole, as opposed to looking at these little individual joints and getting caught up in degrees of motion and these little details. So
For sure.
just a thought to challenge you if you find that that's a tool you're using a lot. Challenge yourself to be like, what's the bigger picture here? Obviously, the number is important for reimbursement purposes at times, but always be challenging yourself. How can you think about this bigger, and how can you relate this to a bigger picture?
Yeah, I mean, you always play devil's advocate, so I'll take my turn here. But we believe more so in like a test retest. Like you should always use the measurement as a validation of your process. And if 3 to 5 degrees gets you a range of motion on someone that's a total knee replacement that's stiff, that's a relatively appreciable change. If it's someone that really is struggling to trust your hands, and there's more of a neurological barrier going on, like 3 to 5%, and you just cranking and almost like forcing that extra 5 to show that you did something, that's maybe not what we're doing
What's
here.
wrong with that?
So,
Thanks for listening to KIMEcast. This was KIMEcast, and we are the KIME Human Performance Institute. Thank you very much for listening. We'd love to continue the conversation with you. please hop on our social media. It's at KIMEHPI and engage with us there. If you'd like us to feature a topic or answer any questions live on the show, post your comments there. You can also check us out on our website at kimeperformance.com, and there you can see links to content that we've posted throughout our podcast for more information.